J.D. Corl, interventional cardiologist at the Christ Hospital in Cincinnati, Ohio, and today I'm going to talk about the Shockwave L6 device. Heavy calcium is challenging in all vessel sizes, but especially in large vessels. These are high-risk vessels with limited treatment option, and calcified plaque negatively affects the procedural success and long-term outcomes. Currently, we have four main treatment options for heavily calcified vessels: standard balloon angioplasty, atherectomy, stents, and lithotripsy. Standard balloon angioplasty is often limited by recoil after the balloon angioplasty. These vessels often require high-pressure balloon inflations to modify the plaque, and that high-pressure inflation can lead to dissection, perforations, and embolic risk. Atherectomy is another option to treat heavily calcified vessels, but this is limited in large vessels. We typically don't use atherectomy in iliac vessels, and again, there is increased risk of dissection, perforation, and of course, embolization with atherectomy. We often have to treat heavily calcified vessels with stents due to suboptimal results with balloon angioplasty. And in large vessels, typically iliac arteries, we tend to stent those vessels with good long-term durability. The stents in high calcified vessels can be underexpanded, asymmetric, and malopposed. So this can limit your long-term durability, increase the risk of thrombosis and restenosis. These larger stents in the iliac arteries require larger sheaths, and that is typically through femoral access for iliac disease, and that can increase your bleeding risk with those larger sheaths. I tend to prefer balloon expandable stents in the common iliac arteries. Again, may require larger sheaths, especially the covered stents. And in the external iliac arteries, I tend to prefer self-expanding stents. Intravascular lithotripsy is a welcome addition to the toolbox to treat calcified vessels, and the L6 device has expanded that treatment use to large vessels such as iliac arteries. The Shockwave L6 catheter does expand our IVL technology to larger vessels. You can see on this diagram, the iliac arteries are ideally sized for the L6 device. The L6 catheter comes in those larger sizes ranging from 8 to 12 millimeters. This helps get apposition in those large vessels for more efficient energy transfer and more effective lithotripsy in these heavily calcified large vessels. The L6 balloon is 30 millimeters long, containing 6 emitters with a compact design of those emitters, giving you a deep penetrating, consistent energy profile across the 30 millimeters of that balloon. Intravascular lithotripsy using the L6 balloon in these large vessels modifies both superficial and deep vascular calcium. This is achieved by delivering pulsatile sonic pressure energy that fractures the calcium. This helps enhance the vessel compliance, this limits recoil, and it helps with subsequent optimization of stent expansion so you get full stent expansion in these calcified vessels. The L6 balloon does all this at low pressure, 2 to 4 atmospheres, which can limit your complications related to barotrauma. The L6 balloon does modify deep calcium. This requires deeper penetration. You can see the energy profile on that L6 balloon compared to the M5 balloon. The M5 balloon is over 60 millimeters, which spreads out the emitters. There's only 5 emitters there, so you're more spread out. You got those 6 emitters in the L6 balloon in that compact design, giving you that deep, consistent energy profile. Some more details about the Shockwave L6 lithotripsy catheter. It's on an 018 platform instead of an 014. It's 110 centimeter shaft working length. Again, the balloon is 30 millimeters long, and it does deliver a full 300 pulses. The Shockwave L6 balloon is ideally sized for common iliac arteries and external iliac arteries. My algorithm typically starts with radial access with imaging from above, not only for diagnostic images, but also for imaging during the intervention itself. I typically start with intravascular ultrasound for plaque morphology as well as vessel sizing. When I do intervene, it's typically from common femoral access. These covered balloon expandable stents do require larger sheaths, so common femoral artery access is often required. We do occasionally treat from radial and I have treated some iliacs from tibial access, but those are unique situations. The lithotripsy has given us a plaque modification option for these calcified vessels. Again, we typically don't use atherectomy in the iliac arteries, but we can use lithotripsy here safely, again, with that low pressure inflation and significant plaque modification to allow for stent deployment. Again, I typically use balloon expandable stents in the common iliac arteries, preferring covered stents, and in the external iliac arteries, I typically use self-expanding stents. Here's a typical room setup for an iliac intervention. Patient is in a standard position on the table, similar to a heart cath, with the head at what we'll call the north end of the table. Again, we typically start with radial access for our diagnostic images, but can use that access point as part of the intervention as well with an R-to-P sheath. But it is important to be able to image from above during the intervention, even if we are intervening from the femoral arteries. It's nice to have that imaging from above to position stents and equipment during the actual intervention. The 30 millimeter balloon length is ideal for iliac arteries. Again, you can treat focal lesions with that without overextending the balloon outside the treatment area. The 30 millimeter balloon can be inflated multiple times, and you have a full 300 pulses to treat a diffuse segment in the iliac artery. So you can cover the entire iliac artery with multiple inflations and plenty of pulses to cover that area. Again, the balloon is 30 millimeters long. There's 3 channels with 2 emitters per channel, 6 emitters total. This compact design gives you that high energy output across the entire length of the balloon and gets you that deep penetration of that energy output. I routinely use intravascular ultrasound to get accurate reference vessel diameters, and I can use low pressure lithotripsy with 1-to-1 sizing with confidence from a safety standpoint. The Shockwave M5 Plus catheter is better sized for SFA and popliteal disease. The diameter ranges from 3.5 to 8 millimeters. The balloon length is 60 millimeters, and it's an 014 wire compatible balloon. The M5 Plus does deliver 300 shocks with 2 shocks per second, and the energy profile is more spread out with 5 emitters over 60 millimeters compared to the L6, which is 6 emitters over 30 millimeter balloon length. The L6 is an 018 wire compatible balloon. The length is 30 millimeters like we've talked about. The diameters range from 8 to 12 millimeters, which is better suited for iliac arteries. And it also delivers 300 pulses at a pulse every second. Again, you have more compact design with the L6 balloon, giving you that higher energy output across the entire length of the balloon for deeper penetration to help treat that deep calcium. These 2 balloons overlap at the 8 millimeter diameter. They both have an 8 millimeter option. The M5 Plus is, of course, a longer balloon, so that may influence which one you choose for the 8 millimeter balloon size. The M5 Plus also has a longer shaft at 135 centimeters, which can help get from the radial artery down into the iliacs or the common femoral. So that may sway your decision as well. And they're both 7 French sheet size for the 8 millimeter diameter balloons. So we will review a case here. We have a 74-year-old male with severe lifestyle-limiting claudication involving both legs, past medical history of coronary artery disease, peripheral artery disease, sleep apnea, hypertension, hyperlipidemia, diabetes, and tobacco abuse. So the usual suspects. The aorta-iliac duplex study showed severe velocity elevations in both common iliac arteries. There's also monophasic flow throughout the iliac arteries bilaterally. Here's our initial diagnostic images. Again, we obtained these images via radial access with an abdominal aortogram. And you can see our IVUS images of both the right common iliac artery and left common iliac artery showing heavily calcified stenoses bilaterally with dense calcium and heavy plaque burden in both common iliac arteries. Here we can see the reference vessel diameters with intravascular ultrasound in both the right common iliac artery and the left common iliac artery. On the right side, we measured up to 11.7 millimeters in diameter, and on the left side, up to 10.98 millimeters in diameter. So these are large common iliac arteries. Based on the intravascular ultrasound images, the 12 millimeter L6 Shockwave balloon was ideally sized for these common iliac arteries. We used 150 pulses on each side using the same balloon. This gave us excellent plaque modification, even involving that eccentric plaque noted on the left side. Following effective intravascular lithotripsy in both common iliac arteries using that 12 millimeter L6 Shockwave balloon, we were able to easily deploy and expand an 11 millimeter covered stent in each common iliac arteries. Post-dilatation was achieved using a 12 millimeter diameter balloon on both sides with an excellent angiographic result. As just mentioned, we had an excellent angiographic result in both common iliac arteries. We did perform a follow-up surveillance duplex study, which showed widely patent stents in both common iliac arteries with normal velocities throughout the iliac arteries bilaterally and multiphasic flow throughout. And more importantly, patient achieved complete resolution of his claudication symptoms.